Hello everyone, welcome to your second lecture on the cardiovascular system. In this lecture, we will talk about hypertension and heart failure. These are the learning objectives that we will be covering. Let's talk about hypertension first. What's the pathophysiology of hypertension? First of all, some important terms: cardiac output. What is cardiac output? We mentioned this in the previous lecture as well. Cardiac output is your heart rate times the product of your heart rate times your stroke volume. Your heart rate is what? 60 to 100 beats, right? Times your stroke volume. Your stroke volume is the difference between the end diastolic and the end systolic volumes. It's the volume ejected with each heartbeat, right? For the normal range for an average healthy person is 50 to 100 milliliters, right? And then we multiply that by your heart rate, which is an average of 60 to 100 beats. Blood pressure is, created by the difference in pressures of the blood as it leaves the heart and the resistance it meets flowing out to the tissues. Remember, we said the left ventricle contracts, pushes blood out into the aorta, and you have resistance in the aorta. That's the systemic vascular resistance, the resistance that it's getting as it's being pumped out. And so your blood pressure is actually your cardiac output times the resistance, the systemic vascular resistance, right? And this resistance is influenced by weight, stress, smoking, activity levels, your diet. So your heart rate could be very high, but that doesn't mean that more blood is being pumped out into your body. Because remember, if there's too much resistance, then you're not getting enough cardiac output. And so it's not a healthy thing. The more the resistance, the less the cardiac output. So hypertension is a persistent seated blood pressure level. That's when a person is seated, equal to or greater than 140 over 90 millimeters per mercury. And remember, this has to be on two separate occasions, right? For example, when a person comes to the doctor's office, they check their blood pressure, the blood pressure is high, they're going to be asked to come back in a few weeks and they're going to check their blood pressure again. So once their blood pressure is high on two separate occasions, then it's considered persistently high blood pressure, elevated blood pressure. What is the pulse pressure? The pulse pressure represents the driving force of your ventricle. The wider the pulse pressure, remember we said, what is the pulse pressure? The pulse pressure is the difference between your systolic and your diastolic blood pressure, right? So if it's 120 over 80, then that'll be 120 minus 80, which is 40, right? So a wide pulse pressure indicates increased working of the heart. That means your heart is being overworked. And this is what we see in older adults. They have a widened pulse pressure. So essential primary hypertension is hypertension, elevated blood pressure with no known cause. It's idiopathic. Okay. Secondary hypertension, it develops in response to identifiable mechanism, I'm stuttering, or another disease. For example, maybe hyperlipidemia, you had high cholesterol, then that caused your hypertension, right? Secondary hypertension. It's the most common chronic disease amongst adults, right? Each increase of 20 millimeters of mercury in your systolic pressure or 10 millimeters of mercury in your diastolic pressure doubles the risk of death from stroke or heart disease. Most patients with hypertension can lower their blood pressure through lifestyle changes. What are these lifestyle changes? Okay, once again, that's diet, exercise, making sure they're taking their medications, and smoking cessation. These are the most recent categories of blood pressure according to the American Heart Association. Normal is systolic less than 120 and diastolic less than 80. Elevated is 120 over 129. 120 to 129 systolic, and still less than 80 diastolic. Remember, notice the diastolic is still less than 80. High blood pressure, that's stage 1, is when your systolic blood pressure is between 130 to 139, or your diastolic blood pressure is between 80 and 89, and it's less than 90. High blood pressure stage 2 is when your systolic blood pressure is 140 or higher, and your diastolic is 90 or higher. So these are the, that's your normal elevated stage 1, stage 2. Then after that, we have hypertensive crisis. This is, where you have to consult your doctor immediately. It's an emergency, right? That's when your systolic is higher than 180 and your diastolic blood pressure is higher than 120 millimeters of mercury. This can lead to a stroke, and it's extremely important to tell our patients that if they ever have elevated blood pressure like that, a hypertensive crisis, to notify the provider immediately. How does a person develop hypertension, right? One of the major causes is atherosclerosis. This happens when we eat high cholesterol foods, high fat, high in saturated fats and stuff, the bad oils, right? This is where, our diet causes these plaques. If you notice on the inside walls of the veins, you have these plaques, right? And if those plaques are there, then it narrows these vessels, and that can cause hypertension. Obesity is another major factor for atherosclerosis. Then we have physical and emotional stress. During stress, people's blood pressure goes higher. Or physical stress, when they're sick, sometimes the blood pressure goes higher. Smoking, once again, we said, it constricts the vessels, and so it increases, blood pressure. Excessive caffeine intake. This is excessive amounts of caffeine, right? Just one cup of coffee is not going to do that much of a damage. Then we have hyperthyroidism. People who have a very, hyperthyroid functioning, they can also develop high blood pressure. Then you have hereditary factors. If you have generational high blood pressure, parents, grandparents, if it runs in your family, then more than likely, a person will get hypertension as well. What are the symptoms? Now we have to remember, hypertension damages our organs, right? That's called target organ damage. Now, most people, hypertension is called a silent killer because usually you don't have symptoms. It's asymptomatic. When we start seeing symptoms, then we know there has been some damage to organs, and so it's asymptomatic until TOD is done, right? What symptoms are you going to notice? You're going to notice increased blood pressure, headaches in the occipital areas, especially in the morning times. We call them morning headaches. Failing vision due to retinal damage. Damage to the kidney. That means you're going to see low perfusion, right? Ringing in the ears, tinnitus. Weakness, tingling in the hands and feet, is also a symptom of high blood pressure. Anginal pain, chest pain, is a sign of hypertension. Systemic edema, especially in the ankles, and that's where we usually notice it in patients, is in their ankles. Now, if the high blood pressure is not controlled, what can go wrong? These are the complications. You can end up with a stroke, vision loss, heart failure, heart attack, kidney disease or kidney failure, and sexual dysfunction. And there are a lot other, more complications, but these are the major complications that a person can develop when they have uncontrolled hypertension. So how do we treat it? Right? There's a stepped care management of hypertension. Right? Step 1 is lifestyle modifications. It's not only step 1, but it's the most important step of management of hypertension. And once again, what were these lifestyle changes? The weight, exercise levels, the diet, stopping the smoking, reducing alcohol intake. All of these are lifestyle changes, right? So now step 2 is when the lifestyle changes do not help and the blood pressure is still elevated. Then you have step 1. That's the next step now. Includes step 1, lifestyle changes plus 2 drugs. They usually start people off with a diuretic, with another blood pressure medication to reduce the volume. And so that ends up reducing the blood pressure. So it can be a diuretic with an ACE inhibitor, a calcium channel blocker, angiotensin to, your ARBs, right? So it's one of, they get 2 medications and they're required to do lifestyle changes. Step 3 is when you still have an inadequate response. We also want to ask, then the next step, is lifestyle changes and 3 medications. This is when your drug dose is increased or another class of drugs is added to the 2 drugs that you're already taking. Step 4, if there's still an inadequate response, then another medication is added, another 4th medication, a 3rd agent or diuretic is added if not already prescribed, right? So this is how we, this is the treatment for hypertension, how hypertension is managed. Now, one important thing that we have to always think of is that, the number 1 cause of stroke in hypertensive clients is non-compliance with their medication regimen, right? And so when a client comes back and they're, say, on, step 3, it's important, or step 2, we need to ask them, hey, are you taking your medications? Have you been taking your medications? Because most of the time, like I just said, the number 1 cause of complications from hypertension are non-compliance with medications. Okay, so let's talk a little bit about these, lifestyle modifications. We have a weight reduction, maintaining a normal BMI, ideal body weight. Make sure we educate our patient as to what's their ideal body weight for their height, right? Then we want to teach them about the DASH diet. And there's a link in this PowerPoint that, will take you to a site where you can learn more about the DASH diet, right? Where this is a diet rich in fruits, vegetables, low-fat dairy products with reduced, saturated and total fats. Then we want to definitely talk to our patients about decreasing their sodium intake. So the amount of sodium to be taking in should be always less than 2 grams is the optimal gain. But aim for at least 1,000 milligrams a day. That's 1 gram. Especially if, you already have hypertension, we need to encourage them to decrease their sodium even more. Dietary potassium. The potassium should be about 3,500 to 5,000 milligrams a day. We should encourage them to choose high potassium foods and teach them how to check labels to see how much potassium that food item has. Physical activity. We need to encourage patients that they should do regular aerobic physical activity, for example, brisk walking for 90 to 150 minutes a week, right? Regular dynamic resistance training for about 90 to 150 minutes a week. Regular isometric resistance training at least 3 times a week. And we're going to talk more about these exercises and stuff when we cover musculoskeletal system. And then we have moderation of alcohol consumption. Alcohol should be limited to less than or equal to 2 drinks. And how big are these drinks? 24-ounce beer, for example, 10 ounce of wine, or 3 ounce, of whiskey per day in most men, and less than or equal to 1 drink per day for women. For women, they need to have taken even less alcohol than men. What is resistant hypertension? That's when the blood pressure is not controlled. That means it's greater than 130 over 80 millimeters of mercury with 3 hypertension medications. So the patient is taking 3 medications and their blood pressure is still not controlled. First, we're going to ask our patient, what? Have you been taking their medications? Explain to me how you've been taking these medications. Which one do you take at what time? Most of the time, like we said, non-adherence to medication regimens is the biggest problem. So if the BP is, controlled with four, even with, is not controlled, sorry, with four antihypertensive, then make sure they're taking the medication and evaluate for possible secondary hypertension. Maybe there's another underlying cause for, that hypertension. Please go ahead and review the hypertension assessment sheet I provided in Canvas. We will review that in class together as well, but please review it before you come to class. Let's talk about heart failure. If you look at these two pictures here, what do you see? What difference do you notice? I'll give you a second to look at them. So if you notice, we said, remember the ventricle wall? If you notice, this is nice and thick because the ventricle, this little chamber, has to pump enough blood out of the aorta to circulate your entire body. Think about it, this fist-shaped organ, and this little area right here has to pump enough blood with enough force to circulate the entire body, right? So that's the reason why this wall is thick. And then if you look over here, what's happening over here? It's thinning, right? So if it thins and it dilates like that, it's like becoming dilated, like becoming wider and thinner, then what's going to happen? It's not going to be able to pump enough blood into the aorta to perfuse the entire body, right? And this is a picture of of heart failure right here. So let's talk about the pathophysiology of heart failure. Heart failure is the inability of the heart to pump enough blood to meet the tissue's oxygen demands, right? Your entire body needs blood. It needs oxygenations and the nutrients, and is depending on that fist-shaped organ, fist-sized organ, very small organ with a lot of, very hardworking and has a lot of demands on it. So you can have systolic heart failure or diastolic heart failure. Primary underlying causes. What are the primary underlying causes of heart failure? Ischemic heart disease, MI, cardiomyopathy, valvular heart disease, hypertension. All of these can lead to heart failure. Now, this is systolic and diastolic heart failure. The differences. In systolic heart failure, it's what we call a pumping problem. Systolic heart failure is a pumping problem. It's the inability of the heart to pump sufficiently because, remember we said, it's alteration in the ability of the heart to contract. It's getting overdilated, the walls are getting thin, and it just cannot pump. It just cannot contract. So now when it's not pumping with enough force, it often occurs after cardiac cell muscle death. Either there's ischemia, right, or less muscle to pump the same amount of blood. Remember we said the wall is getting thinner, so there's less muscle to pump it. Then this is also known as heart failure with reduced ejection fraction. And you'll see this phrase used, when you go to clinicals and you have these patients with heart failure and stuff, right? Remember we said, what's the ejection fraction? Normal is 55 to 70%. Less than 40% indicates heart failure, right? And so systolic heart failure is usually known as reduced ejection fraction heart failure with reduced ejection fraction, right? The percentage of diastolic volume that is ejected from the ventriculars during systole. It's the most common type of heart failure. Then we have diastolic heart failure. What is diastolic heart failure? That is a filling problem. Like systolic is a pumping problem, diastolic is a filling problem. So thicker muscles mean more pumping power, but less filling space. So what's happening is that, yes, the heart can pump and contract and pump the blood out, but there's not enough blood filled in the ventricle that it's pumping out. So there's not enough blood. This is also known as heart failure with preserved ejection fraction. So systemic pulmonary hypertension, it increases, pulmonary hypertension increases afterload. What is the afterload? Remember we talked about preload, and afterload? That's the resistance to the blood that's being pumped out, right? So this, increases the cardiac workload, the workload of the heart. And it leads to hypertrophy or myocardial muscle fibers, of the muscle fibers, basically the muscles of your heart. Hypertrophy, where your muscles get overly thick, right? And so there's not enough space for the blood to fill. Now, sustained hypertension eventually will lead to changes that impair the heart's ability to fill properly during diastole, because remember we said during the diastolic period is the resting period where your ventricles are not contracting, they're resting because the atria are filling the ventricles, right? With hypertrophied ventricles, they may not have enough space to fill the blood. So left-sided and right-sided heart failure. Left-sided heart failure can cause what? Pulmonary edema, left ventricular failure. This can result in pulmonary congestion due to the inability of the left ventricle to pump blood to the periphery. What are the symptoms that we're going to see? And we're going to see pulmonary symptoms with left-sided heart failure. When you think left-sided heart failure, think lungs. Think your pulmonary system, right? It's going to cause pulmonary congestion because, and remember, it pumps blood to the lungs, right? And then the lungs bring the blood back. Then from your lungs, the blood comes back to your heart. So now if the, heart is not pumping, taking in properly the blood and pumping it out, that means the congestion, what we call the traffic jam, is happening in the lungs. So with left-sided heart failure, you will notice respiratory symptoms. You'll see dyspnea, orthopnea, crackles, cough, extreme fatigue, tachycardia, fast heart rate, anxiety, restlessness, confusion, paroxysmal nocturnal dyspnea, where you cannot breathe when you lay down at night and you're trying to sleep and you can't breathe very well, you're short of breath, right? You have difficulty breathing. So these are all symptoms of left-sided heart failure. In right-sided heart failure, you're going to mainly see peripheral edema, right? That's your right ventricular failure, right? And so this results in peripheral congestion due to the inability of the right ventricle to pump blood out to the lungs. So now all the blood that's coming back into your right atria then going into the ventricle, and if your right ventricle is not pumping that blood to the lungs, the backup is going to be in your periphery, your legs. Especially you'll notice the swelling in the legs. You have peripheral edema. What are you going to see over here? You're going to see peripheral edema, weight gain, distended neck veins. So everywhere that the blood, when the deoxygenated blood that's coming back into your heart, if the heart isn't pumping, then the backup will happen everywhere, right? Peripheral edema, weight gain, you're going to have distended neck veins because the blood is being backed up, into their veins. You're going to see anorexia, nausea, nocturia, weakness, hepatomegaly, like you're too much, blood back up in your liver, causing edema over there. Then you're going to see ascites. That's where, the fluid is being backed up into your abdominal area. So these are the symptoms that you're going to see in right-sided heart failure. One easy way to remember it is, left-sided lungs, right? And that helps you to, and if it's lungs, then it's respiratory problems. And if it's right-sided heart failure, then you could think rest of the body, right? So that's where all the edema is happening. The backup is happening in the rest of your body. How do we treat heart failure and manage it, right? First, it's diagnosed. It's done, you do a chest x-ray, look at enlarged ventricles. They do a BNP to measure the levels of protein in the heart and blood vessels. High levels indicate heart failure. Then the N-terminal probrain natriuretic peptide, I'm sorry, even I cannot pronounce that, it shows impaired left ventricular ejection, so left ventricular ejection fraction. This happens usually after a person gets a myocardial infarction, a heart attack. What are the management goals? We want to improve cardiac function. We want to reduce the symptoms. We want to stabilize the patient. We don't want them in the hospital all the time. So we want to reduce that risk of frequent hospitalizations. We want to delay the progression of heart failure and extend their life expectancy. We want to promote lifestyle conducive to cardiac health. The treatment is medications, including supplemental oxygen, lifestyle modifications, the DASH diet. Here's the link that you can click on and you can view the DASH diet. Surgical interventions, they might get a transplant, they might get devices to help them, with the pumping, depending on what the problem is. And then education. We want to provide them a comprehensive education and counseling to the patient and family, because heart failure is not the best diagnosis, and life expectancy is not the best with heart failure. Okay, the next step is their nursing process. Please review the heart failure assessment sheet I provided in Canvas, and we will also review it together in class. And that is it for you're all done. That's it for both your lectures on, first one on the cardiovascular system, and then this one on hypertension and heart failure. Please make sure you take your notes, and your guided notes, and review all of those before you come to class. I'll see you in class.